was one of the very early adopters of canaloplasty. I was very intrigued by a surgical procedure that did not bypass the natural drain system, a procedure that did not involve creating a bleb or using mitomycin C. So that sparked my interest back in early 2007, 2008. And since that time, I've performed several thousand procedures with traditional canaloplasty. As far as patient selection, that has kind of evolved. When I first started off with canaloplasty, didn't know much about the procedure or what kind of pressure lowering effect it had. And so I started off cautiously with very early open-angle glaucoma patients. Since becoming more familiar with that procedure, my patient selection profile has just really exploded. My treatment paradigm is such that every patient that I want to do glaucoma surgery on, I think of canaloplasty. Now, not every patient might get canaloplasty, but that is where it lies in my treatment paradigm. Perhaps it would be easier for me to tell you who I don't do canaloplasty on, and that is angle closure patients or those with neovascular glaucoma. But in my practice, everything else is pretty fair game. I've done, as I've mentioned, a lot of canaloplasty procedures, so we took a look at a large case series, about 318 patients. A good half of them were phaco canaloplasty, so we took out the cataract at the same time that we did canaloplasty. And we learned that we had some really great results with canaloplasty 3 years out, so almost a 30% reduction in pressure in these patients. And these patients, unlike other studies that have been published about canaloplasty, were all comers, so it also included severe glaucoma. At 3 years out, these patients were also on less than 1 drop of glaucoma medication, so very exciting results there. We found that there was about 10% of that group of patients that no matter what we tried to do, we could not successfully stent their drain system with a Prolene suture. This group of patients that did not have the stenting procedure actually did just as good as those that did have the stenting procedure 3 years out. In addition to being effective in dropping the pressure and controlling the eye pressure, canaloplasty has a very safe risk profile. So intraoperatively, it is much safer of a procedure than perhaps a trabeculectomy or glaucoma drainage implant procedure. There's no bleb-related complications, and most rewarding is that the patients are actually happy. ABiC is ab interno canaloplasty. Traditional canaloplasty is pretty minimally invasive to begin with, but we wanted to step it up a notch. We don't have to manipulate conjunctiva. We don't have to create a deep scleral flap to expose Schlemm's canal. It's done through a small 1.8 millimeter temporal clear corneal wound that perhaps one has already fashioned when taking out their cataract. Through that small incision, we can actually expose Schlemm's canal from inside the eye. So we're accessing the canal that way. You're also catheterizing canal with the eye tract catheter. And we simply then go around 360 degrees and then pull out. And by pull out, I mean pull the probe out while it's still in canal and at the same time viscodilate. So we're hoping to dilate Schlemm's canal, trabecular meshwork, and the collector channels. Since we first started doing this procedure about 1.5 years ago, we've done several hundred patients. Patients took very well to the idea of the procedure, and seeing the results early on being as good as they were, it's actually quickly jumped to the first thing on my treatment paradigm when I take a patient to surgery. Ab internal canaloplasty, what I first do is do a clear temporal corneal wound. It's usually the size of 1.8 millimeters. I then inject an OVD into the anterior chamber to maintain stability. I then fashion a small paracentesis a couple of clock hours where I'm going to make my initial entry into Schlemm's canal. I'll then take the iTrack probe and place it into the anterior chamber in preparation for insertion into Schlemm's canal. I then use a 27 gauge needle, half-inch needle, and do a small goniotomy, expose Schlemm's canal. I then place the probe into Schlemm's canal and advance it 360 degrees. And then I take the probe out of canal while viscodilating. As I pull the probe out, I viscodilate, and I typically, with ab-internal canaloplasty, will get about 15 to 20 clicks. So it's a good bit more viscodilation than traditional canaloplasty. And we're able to get away with that and with no complications because the anterior chamber has been pressurized with an OVD. With traditional canaloplasty, we didn't want to over viscodilate canal so that we could keep the Decimate detachment complication rate low. But despite the fact that ab-internal canaloplasty, you don't have a scleral leg, you don't form a Decimate's window, and you don't have suture tensioning. The preliminary data is very impactful in that it is a procedure that appears to be very effective. Now, we do have insight with our traditional canaloplasty patients, those that did not get suture tensioning. We do have long-term data to show us that this procedure has promise, in that those patients who did not get suture tensioning were doing really well at 3 years out. So I think there's great promise for this procedure.